Good afternoon, everyone, and welcome to the National Council for Behavioral Health webinar, Get the 411, Everything Primary Care Providers Should Know About Parent Training in Behavior Therapy While Working with Families with Young Children with ADHD, the second webinar in our three-part webinar series on evidence-based and evidence-informed parent training and behavior therapy for young children with ADHD. To register for the last webinar or to rewatch the first webinar, please visit the link on your screen. I want to also acknowledge and thank our funder. This webinar series was made possible with funding through a cooperative agreement with the Centers for Disease Control and Prevention. My name is Shalina Fodderingham, and I serve as Director of Practice Improvement with the National Council for Behavioral Health here in Washington, D.C. I will be serving as your moderator for today's webinar. As a primary care provider who treats young children with behavior problems or ADHD, it can be very difficult to find the resources and professional supports parents need to help their child while supporting positive child growth and development. As we know all too well, young children with behavior issues not only impact the child, him or herself, but the entire family. In this webinar, primary care providers will learn about parent training and behavior therapy and why it's an important first step for helping young children with behavior problems, including children with ADHD. By being trained by a therapist in behavior therapy, parents can learn parenting strategies that encourage positive behaviors and discourage negative ones. Behavior therapy for young children with ADHD gives parents the knowledge, tools, and skills they need to help their child succeed. And this is the very reason that we're here together today, to foster positive child growth and development in healthy families. And we're thrilled with the response that we received when we announced this webinar. Can you believe that more than 500 of you have registered to join us today? Your enthusiastic response has helped to reinforce to us and to the CDC how high the level of need and interest is for this information. We do not want this to be the last time that we interact with you, so at the end of this webinar, a brief survey will pop up on your screen. Please take a few minutes to fill out the survey. We will be using these results to improve future webinars and to understand any additional information and training needs you may have related to this topic. For those of you who wish to receive CMEs, CNEs, and other continuing education units, you must complete a separate evaluation form. The link to this form will be both sent to you in an email following this webinar and can also be found in the survey at the end of this webinar as well. Please copy and paste the link into your browser and follow the instructions indicated. And if you have any questions, you may contact my colleague at any time, Crystal Canare, at Crystal, Krystlec, at thenationalcouncil.org. Before we begin, I would like to cover a few housekeeping notes. Today's webinar is being recorded, and all participants will be kept in listen-only mode. In order to hear today's webinar, you must either use your computer speakers or you can dial in to the conference line at 1-888-727-2247 and use the conference ID 347-8556. Questions may be submitted throughout the webinar by typing your question into the Q&A pod within your GoToWebcast window and sending it to the organizer. We'll answer as many of your questions as time allows after all of the speakers have presented today. If at any point during the webinar you experience technical difficulties, please check your system requirements by clicking the question mark located at the top right of your screen or call tech support at 866-678-2846. Before I turn it over to our first speaker, I'd like to talk about the structure of today's webinar. During the first hour or so, we will hear from our two speakers, Dr. Georgina Peacock and Dr. Dave Anderson. And after they've presented, we'll provide you with an opportunity to ask these experts questions for the remaining 30 minutes. As a reminder, you can submit questions throughout the presentation by typing them into the Q&A pod within your GoToWebcast window. We'll have our faculty answer as many of your questions as time allows. So, Dr. Georgina Peacock is the Director of the Division of Human Development and Disability at the National Center on Birth Defects and Developmental Disabilities at the Centers for Disease Control and Prevention. Dedicated to the health and development of children and adults across the lifespan, she applies her personal passion and knowledge to leading the division's surveillance, research, and programmatic activities. DHDD helps children and adults with disabilities get the most out of life by facilitating better health care, increases in accessibility, and inclusion. DHDD also works to optimize child development for those at risk for high-impact conditions so children can reach their full potential. In addition, Dr. Peacock continues to practice and sees patients as a developmental behavioral pediatrician. We also have Dr. Dave Anderson, who is a Senior Director of the ADHD and Behavior Disorder Center at the Child Mind Institute. Dr. Anderson specializes in evaluating and treating children and adolescents with ADHD, behavior, anxiety, and mood disorders. His expertise includes behavioral parent training, school-based consultation and classroom behavior support, and cognitive behavioral therapy. Dr. Anderson is devoted to promoting open dialogue and destigmatization of mental illness, and he is passionate about disseminating evidence-based interventions across diverse communities. He frequently lectures and leads workshops for policymakers, parents, teachers, and schools on all types of topics such as behavior management at home or at school, ADHD treatment, sibling conflict, school mental health support, and challenges in foster care and adoption. Dr. Anderson has contributed to media and mental health outreach for organizations such as Time, WebMD, Scholastic, New York, ABC New York, and Yahoo. Dr. Anderson received his bachelor's degree from Dartmouth College and his doctorate in clinical psychology from Columbia University. We are so pleased to have both of you with us today and to learn from your expertise. To start, let me now turn the microphone over to Dr. Georgina Peacock.
Thank you, and thank you for having me today. If you can advance to the next slide. About 6.4 million children in the United States have been diagnosed with ADHD. It's a behavioral disorder that can cause children to be overly active, have trouble paying attention, or difficulty controlling their behavior. And it often lasts into adulthood and can result in significant problems at school, with friends, and at home. Children and adults with ADHD experience higher rates of injury, academic and career failure, and earlier death. When we're talking about young children with ADHD, we're talking about children with challenging behaviors. And by the time a parent comes to meet with me, they're tired and worried about their child's safety. They're concerned that their child might jump down a flight of stairs, that their child might get lost in a grocery store, or that their child could be kicked out of preschool. So about 2 million of the 6.4 million children with ADHD were diagnosed when they were only 2 to 5 years of age. Children who are diagnosed at these young ages often have the most severe symptoms, and their parents often seek additional support. Next slide. One of the tools to help these parents is what we're talking about today, parent training and behavior therapy. And since 2011, the American Academy of Pediatrics has recommended that healthcare providers refer parents to training in behavior therapy first, before prescribing medicine to young children. However, according to the Vital Signs report, only about half of young children received any form of psychological services, which might have included behavior therapy. And in contrast, about 75% of young children being treated for ADHD received medicine. Next slide. Why is this important? So research shows that when parents are trained in behavior therapy, it can be as effective as ADHD medicine for young children without the risk of health side effects. Side effects of ADHD medicines include poor appetite, stomach aches, irritability, sleep problems, and slowed growth. Also, we don't know about the long-term effects of these medicines in young children. That's why behavior therapy is recommended as the first step in the treatment of young children with ADHD. Research shows that the benefits of behavior therapy can last for years. Medicine works quickly, but the effects end when the medicine wears off. Behavior therapy results in lasting gains and improved functioning even when the therapy has ended. Finally, behavior therapy is effective for children with a variety of behavior problems. It's often difficult to make an accurate diagnosis of ADHD in young children. Therefore, behavior therapy can be recommended even if it's not certain whether the child has ADHD or a different kind of behavior concern. Parent training in behavior therapy is also known as behavioral parent training, behavior management training for parents, parent behavior therapy, or just parent training. Next slide. And now I'll turn it over to Dr. Anderson for a little bit, and then it'll come back to me. Thanks.
Thanks so much. I'm excited to get a chance to talk about this today. So what I'm basically going to do over the next, say, 30 minutes or so is to talk a little bit about the background of behavioral parent training and its development, then talk about what it actually looks like in practice with parents. So first, a little bit about the evolution of behavioral parent training. So we want to kind of think back, and really for many of us it's not going to be that far back, but to the late 60s and early 70s, and to the kind of genesis of these approaches. Part of this came out of research on parenting styles. And for many of us, we've heard about parenting styles like permissive parenting, authoritarian parenting, and authoritative parenting, and thoughts about how we could balance a parent's level of nurturance toward their child as well as the level of structure that a parent might provide to their child, making sure that children get kind of the right and developmentally appropriate helpings of each to foster their appropriate development. This also comes out of Connie Hanft's work, and this is somebody who was working in Oregon and who inspired a lot of the models of behavioral parent training which are currently in use today and have the most evidence behind them for their effectiveness. And the way that this started was Connie Hanft was thinking about how she could translate play therapy skills, which she knew to be really helpful in fostering children's emotional regulation and in helping children to express their emotions and to feel like there was a supportive person there to express those emotions too, how she could also balance that with parental rule setting and parents getting better compliance from kids who are having behavioral issues. So she created these two phases, a child's game, in which the object was to teach the parent skills to follow the child's lead, and a mother's game, in which the object was to help a parent to set clearer boundaries with their child and to foster compliance in situations when compliance really needed to occur. The reason why these treatments were so innovative was that up until that time, the thought was that if you have a child with behavioral issues, the way that you would change those behavioral issues or treat them was involving the child individually. A therapist would meet with the child, they would talk about the reasons for those behavioral issues, and then send the child home, hopefully with some improvement in behavior. The issue was that what the evidence has shown, not only then but also in the 40 years since then, is that there's weak evidence for individual therapy for behavior problems. And that's across the developmental spectrum, whether it's young children, middle childhood, or even for teenagers, that parents are absolutely the agent of change in these interventions. And that if we're going to intervene effectively for behavioral issues, it involves training the adults in a child or a young child or an adolescent's environment, and then intervening at the point of performance or when that child might be demonstrating that behavior, whether that's at school or at home or with their friends. So, going from the evolution of behavioral parent training into the research body that's been collected over the last 4 decades, behavioral parent training is a well-established treatment with decades of research. It is not aimed at treating the core neuropsychological symptoms of ADHD. So for young children, it may still be unclear whether those neuropsychological symptoms are present to a level that is clinically severe, not to mention that we're not trying to target those neuropsychological symptoms. What we're doing is addressing the management of the behavioral symptoms associated with ADHD. So the fact that while a child may be distracted or they may have difficulty sustaining their attention like their peers, what we're really targeting are the behaviors that come along with that, the lack of work completion, the sense the child could be distracted within the classroom, and the frustration on the part of the adults who are trying to manage those behaviors. So the significant changes that we see with behavioral parent training, the things that drop out of almost every research study on these models, are that we see an improved quality of parent-child interaction, We see increased parent confidence in managing child behavior. And probably most importantly to parents, we see decreases in parent ratings of their own child misbehavior. And those are using objective questionnaires that have been normed on thousands of children in a particular age group to ensure that we're seeing the same treatment effects across models. One of the other amazing things to come out of the literature on behavioral parent training is the robust retention of treatment gains, that at 1 and 3 year follow-up, parents still report the same decreases in child misbehavior. And as we'll get to later on in the presentation, this is after only 8 to 20 weeks of intervention. So in terms of cost-benefit or cost-effectiveness, we're talking about something for a relatively low investment of 3 to 4 months of, say, a parent's or parents' time. They can really see significant changes in their children's behavior that hold up 1 to 3 years on. So in terms of the evidence-based psychosocial interventions, Dr. Peacock already hit on this, but the table that I've displayed here is just looking at the level of evidence for certain interventions. Behavioral parent training is over on the left there under the level 1 well-established interventions for ADHD. And these are psychosocial interventions, or interventions that involve manipulating the environment, not necessarily providing medication. And what you can see is that behavioral parent training is under the well-established zone, as is behavioral classroom management and behavioral peer intervention. One of the things that I like to make sure that I direct people's attention to is that what you will not see on this distribution is individual therapy for a child. There's not evidence that that's necessarily effective for behavioral issues or ADHD symptoms in young children. And what you will also see is that social skills training alone, and in that sense what we mean is having kids in a group together training on social skills with no adults trained on how to effectively translate those social skills to the child's school or other social environments is not effective. So we want to make sure that we're always thinking about training the adults in a child's environment on how to get or promote the best behaviors. One of the other pieces of the literature that I think is particularly important is that Bill Pelham, who's a very famous researcher in this area, has done a study on sequencing showing that the outcomes are actually better when parents start with behavioral intervention if they're going to choose to start with either behavioral intervention or medication. And this is partly because behavioral intervention takes a lot of effort. So what we expect is that if parents are just presenting for therapy, we want to use behavioral intervention as kind of a first line for young children with ADHD, but we also want to make sure that where effort and motivation are the highest, we're starting with that intervention, and then later on we may make a decision about whether other interventions need to be added. So, going into some of the essential components of behavioral parent training. In almost every model of behavioral parent training, you see the following principles outlined in kind of rainbow colors, which I basically do because I think it looks nice. But what we're trying to help parents to do is get out of certain traps that parents might get into around their children's behavior. And those traps might be, one of the ways that that Rex Forehand talks about these kinds of traps is that what parents will do is when their child is behaving badly, they'll think that they need to address that behavior, that they need to do something about it and make sure the child understands how wrong their behavior was. And similarly, when the child is behaving well, oftentimes we'll hear parents talk about how they don't want to jinx it, or they're walking on eggshells, or they want to ensure that the child doesn't get off of the particular trajectory they're on in that moment of good behavior. And that's actually the exact opposite paradigm to what we want parents to be thinking about in behavioral parent training. That in fact, good behavior and attention to good behavior is the real currency of change. It's that when a child is behaving well and we pay attention to it, we're more likely to see that behavior recur. And similarly, if a child is behaving badly, we want to really consider whether or not this is a situation where we can perhaps redirect the child effectively or pay attention to something else, or whether or not we actually need a punishment. Because the other piece that parents get into in terms of a trap is that parents will start thinking that they need to get into what we call the coercive cycle, which means that their child does something negative, so they assert their authority and may escalate their voice or start yelling, and then at some point their child might start yelling, and the parent and child get into this power struggle back and forth where everyone's raising their voices and becoming more emotionally dysregulated. And eventually, one side likely is going to win in some way, and this gets reinforced over and over as something that both parent and child think are effective at getting their way. A parent will decide, if I yell loud enough, my child will listen, and a child will think, not necessarily consciously, if I tantrum enough, I will get out of doing whatever it is that I don't want to do. So what we help parents to do are to think about planning ahead for the good behaviors that they would like to see, how they themselves can model those behaviors and show their children the kinds of emotion regulation they'd like to see, the kinds of sharing behaviors they'd like to see, the kinds of behaviors toward other people in the family that they would like to see their child demonstrate, and then similarly how those parents can teach their child about those expectations in moments where the iron is cold. In other words, emotions aren't running high, and we have a time when we can have more discussion and possibly more teachable moments around good behavior. The second thing that we do is we try to make sure that parents get as much distance as possible out of attending to and reinforcing positive behavior. And that's often something that takes a lot of practice. Parents, even when they conceptually understand that they should be attending to and reinforcing positive behavior, will have any number of objections to this. Do kids really need praise? Is too much praise a bad thing? Is there a certain way I should praise positive behavior? Will my child become dependent on rewards? This doesn't feel genuine to me. This doesn't feel automatic. I don't know that this feels natural. My kid thinks something weird is going on. And if we can get someone to push through those moments, to really see the benefits of an intervention like this, we often see immense improvement. And that's often the kind of nuances that we need to see in providers at the community level, is their ability to answer those questions and help parents to continue practicing the strategies so that they'll see those benefits, which often come at least 2 to 4 weeks into the initial stages of parent training. The next principle that we train parents on is how to actively withdraw their attention from minor misbehavior. And this is a very nuanced point. We teach parents how to redirect a child without paying attention to a negative behavior. We teach parents how to ignore without freezing out the child or letting their emotions get the best of them. And this is something where when parents are withdrawing attention, there are a lot of ways that in particular the word ignore is misinterpreted. We want to make sure they have a guide and a coach about how to best redirect a child to better behaviors or ignore and pay attention to a behavior the child might be demonstrating that is better, or give a child choices of something that the parent might be okay with while at the same time is incompatible with whatever the child is doing. The next principle is we teach parents how to give effective directions that are developmentally appropriate. With young kids, that means being very direct, telling a child what to actually do, making sure that you give commands one at a time, making sure you reinforce compliance after each of those commands, making sure the language is developmentally appropriate, and there are a host of other rules that increase the chance that a parent might get compliance even just by obeying the rules of giving good directions. And the final piece is we help parents understand what punishments have a record of being effective, as in loss of privilege or timeout, and what punishments do not have a record of being effective in terms of managing misbehavior. So there's a lot that we talk about around spanking for many families in helping them to understand both the research around spanking and the reason why spanking itself is not an effective punishment. And then we help parents to apply principles of good punishment for misbehavior, meaning that it's sparingly used, that it's used incrementally. In other words, the child does not lose all of their privileges at once or is not in timeout for a very extended period of time that's developmentally inappropriate. And along that line, we help parents to realize that while punishment can stop a negative behavior in its tracks, it may not necessarily promote positive behavior in the future. Just because you're told to stop doing something doesn't mean that when you get into a situation, a little ways down the road, you know what you're supposed to be doing. You may only know what you're not supposed to be doing. And so for that reason, we want parents to understand the balance between punishment and reinforcement, between structure and nurture, and the need for both of these things in promoting positive child behavior. In terms of the format of behavioral parent training, I'm not going to go through the table on the left in great detail, but the table on the left gives kind of another conceptualization of those principles I just talked to in rainbow colors on the last slide. But it's the typical sequence for many parent training models in terms of moving through these various modules with parents. And that sequence might go over the course of, say, 10 weeks of introducing new material each week, but you also might spend a few weeks on certain modules if those things are not being applied at home. Because behavioral parent training has such a focus on homework and on the application of strategies, it isn't just about teaching parents those things. Talented therapists in behavioral parent training should be able to get parents to actually apply these strategies. And if they're not applying them, they should be able to live coach the parents in actually applying these strategies in the course of a particular session. The other dominant model, outside of introducing modules kind of in sequence and then spending a few weeks on modules where parents might be having trouble applying them, is the two-phase approach. This is an approach that's actually fairly common in, say, models like parent-child interaction therapy or helping the non-compliant child. And the two-phase approach, especially for young children, is really effective for both parents and children in the sense that it focuses on phase one, being very similar to the original Child's Game that Connie Hanft had come up with. It's focused around promoting positive behavior and improving the quality of the parent-child relationship, and increasing attention to positive behavior, reinforcing the good behavior we see. So that first phase is centered around nurturance. How do we make sure that we're building more of an emotionally supportive environment between parent and child, that we're staying regulated, and we're promoting positive behaviors? Then the second phase is where we build in the structure. We teach parents how to give clear directions, how to apply age-appropriate consequences for misbehavior, how to improve their child's compliance, and how to decrease negative behaviors. In PCIT, the way that this looks, for example, is that in the first phase, there is a teach session with parents where parents are taught these skills, and then you do a number of practice sessions in which parents are coded during every practice session engaging in the skills until they reach mastery on that set of skills. And you only move on to phase two once parents have mastered those skills in phase one. As you move to phase two, it's the same thing. You do a teach session with parents, then you practice the skills in the session, and at the end of PCIT, you actually start doing what we call public behavior practice, meaning that you go from the office where you've been practicing these skills in lower demand situations, and you move into public environments where you're practicing these skills. Just in the last couple weeks, I've gone clothing shopping with families, to department stores, to a candy store, to the park, taking walks down the street, and safely navigating across lanes of traffic while holding a parent's hand and behaving safely. So there are lots of possibilities for public behavior practice that parents ask us to accompany them and coach them on how to effectively manage their child's behavior. In terms of the course and delivery of behavioral parent training, when parents ask how long treatment is, this is always a difficult question because for behavioral parent training, contrary to kind of older models of psychotherapy, it's not about whether the psychotherapist thinks that the family is ready to graduate. It's often dependent on whether the family is A, applying the strategies at a high level, and B, whether the family feels confident that the behavioral issues that they came into treatment for have now been at least to some degree resolved. So what we tell parents is that the purpose of behavioral parent training is for you to no longer need the therapist. It is not for therapy to go on for years and years and years. So the object is to teach parents skills and make sure that treatment can go from 8 to 20 sessions. For those of you who are asking if you get a certificate of completion, yes. Many therapists really love giving certificates of completion at the end, partly because we want to help to kind of tie up the experience, to let parents know that they've mastered a certain set of skills, and to provide a reminder that they can take home with them to remind them of those skills that they should be practicing. So graduation certificates are widespread, partly because the treatment is short and you're focused on skills mastery, and there's obviously a clear moment where treatment might end and you would progress back to applying these skills in daily life. In terms of standard delivery formats, what this means, and I was referencing this in the last slide, is that behavioral parent training should include meetings with parents in which didactics are discussed, as in you're just teaching parents material. It should include, especially for young children, coaching sessions in which the parents are being coached by the therapist to engage in those behaviors with the child or to engage in the skills practice. It's also delivered, in the case of the Incredible Years model, in separate parent and child groups. In other words, a group of parents meet together to be taught the skills and then to talk about how they might apply them at home, and a group of kids meet together, and that's usually focused around social skills. But as I referenced before, those social skills are then reinforced by their parents at home, thus allowing those social skills to translate from the group to other settings. There are some other alternative delivery methods that have been studied in recent years, but that still require a bit more research to prove that they're equivalent to the methods of delivery involving parent didactics and coaching of the parent-child dyad together. Home-based care is definitely one of the most promising alternative delivery methods. The only reason why home-based care might present a larger challenge is that in a different way than therapy done in the office, when we do, say, parent-child interaction therapy in the office, we do it in a room where we put the light switch high on the wall, we have a locked cabinet, only certain toys that we've put out that we know are less likely to lead to negative behavior, and we're coaching the parent through a one-way mirror, and the parent has a bug in their ear. It's a highly controlled situation in which we can manage a lot of variables and make it so that parents can effectively practice the strategies without too many other stressors getting in the way. The only issue with home-based care is that while parents will think that it's more valid because we actually see the situations that they're dealing with, it also means that we really are doing this in the situations that they're dealing with, and it's a little bit harder to be able to practice the strategies in a lower demand situation and to make sure that parents are really applying the strategies at a high level. Phone follow-up is another thing that's being looked at, as in we deliver the strategies intensively and then do phone follow-up calls. This is especially for families that might be coming from a distance and may only be able to come for a few days, and then we need to be able to communicate with them when they're applying the skills later on. And then there's also a lot of pilot studies looking at intensive delivery methods. So taking the once-weekly parent training model and saying, can we do this 2 or 3 times a week? And this is actually something that we're piloting at ChildMind right now, where we're beginning to assign families to intensive versus non-intensive conditions, meaning that I have a family in right now this week who's actually meeting with me for 10 hours just this week. And then they're going back to their home to practice the strategies. They live out of the state. And what we see in general with a lot of these intensive models, that the research is very promising, that delivering all of the parent training at once can actually be equivalent to once-weekly therapy in terms of the treatment effects. So, the other side of this slide, in any given session of behavioral parent training, the other things that parents can expect are that at the beginning of the session, we're going to review skills, homework, and any other sources of stress that might be going on in the application of these strategies or at home. Then there's usually a discussion portion or a skills drill or some sort of didactic where we're learning a new skill. Then there's a large portion of the session. We're usually trying to take up the majority of the session in practice, role play, and coaching, either with the child when it's a very young child, or with older children, it tends to be role play. And then we really review the skills and review the progress made during the session and plan for how the skills will be applied at home. We always assign homework, trying to make sure that parents are practicing the strategies and that they're making time each day for structured situations to ensure the strategies are practiced. So the next slide is mainly the left part of the slide is trying to make sure that all providers are aware of some of the dominant models of behavioral parent training. So that if you hear a parent mention one of these models, you'll know that this is one of the more evidence-based models, and you can with confidence say to a parent, yes, this is what you're looking for a young child with ADHD where you're trying to do behavioral interventions. So a few of the models you might hear about are parent-child interaction therapy, which is one that I've talked about a little bit already, but is generally good for children between the ages of 2 and 7 presenting with behavioral issues or ADHD, and involves live coaching of a parent with a child in the application of skills. Incredible Years, another that I've mentioned, that's delivered in a group format with a parent group that meets simultaneously while a child group is meeting. Child group focused on social skills, parent group focused on behavioral parent training. Then there's Triple P, the Positive Parenting Program. Triple P is innovative in that it has many levels. Those levels can be for parents who need abbreviated parent training. Maybe they're not seeing clinically severe difficulties with ADHD or behavioral issues, but what they are seeing is concerning and they want some help. And Triple P can also, of course, be delivered at a much higher intensity for clinically severe difficulties, not to mention that Triple P has also created a curriculum that's just centered around prevention, meaning that you can go into a school setting or into a community setting or a parent talk, and you can deliver certain modules of Triple P that just generally help with behavior management across age ranges. Helping the non-compliant child is another that I've mentioned. This is Rex Forhan's model. And it's something that also includes 2 phases, one centered on increasing the positive aspects of the parent-child relationship and improving positive behaviors. Then the second phase focused on structure and discipline. There's also parent management training, which is kind of the dominant model that has those kinds of 10-session sequences where you're spending a certain number of weeks on each module in the sequence. And parent management training has 2 models. There's parent management training, the Kasdan model, named after Alan Kasdan, the creator at Yale. And then there's also parent management training, the Oregon model. And that model was, of course, popularized in Oregon and also has been applied in a number of countries across the world in large-scale efforts. Defiant Children is a final model that I would discuss, and that's actually created by a scientist named Russell Barkley. And while Defiant Children, unfortunately, may not have the best marketable name to many parents who may not want to think of their child as defiant, the principles are incredibly sound, and all of these models have the same underlying principles, those principles that were outlined in rainbow colors in an earlier slide. On the right side, the thing that I've outlined is this was from an article that was actually written by, at that time, a postdoctoral fellow at the CDC on a meta-analysis of the components in behavioral parent training that have the largest effects. And this is particularly important for younger children with ADHD. What we want is we want to make sure that we have an aspect of behavioral parent training that's focused on increasing positive parent-child interaction and emotional communication. We want to make sure that, especially for young children, we're teaching appropriate, developmentally appropriate consequences like timeout and the importance of parent consistency. And then the therapies that are the most effective have in-session practice of the skills with the child. So, getting to my final slide for today. How do you know that behavioral parent training is working? The way that we know that behavioral parent training is working is because the mechanisms of action are built into the treatment to ensure high quality, high fidelity in the delivery, and that we're targeting outcomes that we see movement on. So behavioral parent training, like many cognitive behavioral methods of intervention, is characterized by collaborative empiricism, meaning that we, together with the parent, are collaboratively gathering data and trying to make sure that there is a constant feedback loop of data that informs the interventions that we're using. If an intervention didn't work, we want to collect data on the antecedents, i.e. the factors that happened before a particular behavior, and we want to collect data on the consequences, the things that happened after a behavior. Really analyze that data and figure out what we can tweak in the environment to possibly promote the best chance of success for a parent and a child. The reason why we know that BPT works is that it's informed by evidence-based principles of behavioral science. Now, one of the things that's often said about these principles are that there have not necessarily been studies looking at every aspect of a particular behavioral parent training model and figuring out, as part of a component analysis, if every single aspect is effective or needs to be in there. But what we do know, and I used to have a mentor early on in my career who used to say this a lot, what we know is that when we use all of those particular principles, we get fantastic effects. So why would we think of doing anything else? So that's why we really think about how, even though each principle may not have been explicitly tested by itself, together there is an incredibly large body of evidence proving their effectiveness. The next reason why we know that behavioral parent training is working is the clear identification of treatment targets. When we begin behavioral parent training, we focus in exhaustive inventories with parents on what behaviors they're seeing and how we're going to be able to track progress. We want to know how often a behavior is happening. We want parents to take baseline measurements. We want to make sure that when we're tracking treatment progress, it isn't just qualitative reports of it felt like a good week, but rather that we're getting really good representative behavioral data on the targets of treatment, and that we're helping parents to see those effects as well. Next, we're tracking well-validated symptom measures. So we are asking parents how they think the treatment is going and identifying targets from the get-go, but we're also, at periodic intervals, Some behavioral parent training models do it every week, some every few weeks. We are giving parents objective questionnaires validated on thousands of kids in that age group to see where those behavioral difficulties are falling relative to peers. One of the things that's said within the parent-child interaction therapy world is that the object of treatment is to take the objective questionnaire that we have parents fill out during PCIT, called the ECBE, and to make sure that ECBE scores get back to within a half standard deviation of what would be considered normative for that child's age range. And if we can do that, we know that we've brought the child back to a place where their developmental trajectory has likely been restored in kind of alliance with their peers. The next thing is, and I think I've already addressed this, is data-driven adjustments. We're always asking for data and always adjusting our approach. All too often, people think that cognitive behavioral treatment or behavioral parent training is robotic, that we're going to be asking parents to do the same thing over and over. They've heard it all before, and why would they have to do anything different? And what we say to parents is, yes, the underlying principles are the same, but the data is different in every family. And we have to adjust, personalize this, think about any particular family's makeup, their cultural background, their beliefs that are kind of dominant within the family system, and all of those things become aspects of the data that we gather to adjust these treatments to ensure that they're effective for a family. Finally, there are mastery and graduation criteria and certificates to ensure that people have effectively and with great fidelity completed the treatment and made sure that they're applying the skills such that they can see the results. The last point I'll make is there's an incredible research record of fidelity and effectiveness in the time allotted. In other words, when parents say to us, have you used this before and has it worked? We should be able to say to them, yes. Many families see us for a 3 to 4 month period and then decide independently to stop seeing us because behavior has improved to the degree that they expected. And that's something where we can't promise that with every family, obviously, but it's something that should have a very large research basis for anything that would be considered behavioral parent training. We should be able to say something like that about a particular model that might be used. And if we can't say that, it's unlikely we're using a model that's supported by the same wealth of evidence. So with that, I'm going to pause there and transition back to Dr. Peacock.
Thank you, Dr. Anderson. That was a really great and thorough description of behavioral parent training. So I really appreciate you providing all those details. Next slide. When determining what's the most appropriate treatment, there are a number of things that primary care clinicians and parents should consider. They need to understand the long-lasting benefits of behavior therapy. We know that medication works quickly, but the effects end when medication wears off. The behavior therapy, as we heard, has lasting gains and improved functioning even when therapy has ended. There are other things to consider, like cost and other resources, like time and effort required, that may be of some concern to families. But clearly we heard from Dr. Anderson that there are clear benefits after these sessions. Insurance coverage of parent training and behavior therapy does vary by provider. Therapists may not be available in all areas, and certainly availability and accessibility may vary by location. And finally, primary care physicians and parents need to balance the risks of side effects against the urgency of need. So there may be some children that have such severe symptoms or behavior problems that the risks of delaying medicine may outweigh the benefits. Next slide. So when discussing behavior therapy with parents, it's also important that healthcare providers communicate to parents that they didn't cause their child's ADHD, but that parents can play a key role in the treatment of ADHD. They can explain to parents that typical parenting strategies may not always work as well with challenging behaviors, but with a therapist help going through some of the processes that we just heard about, they can learn more effective strategies and skills. They need to also acknowledge to parents that learning and practicing these skills requires time and effort and resources than maybe what you would get initially with medicine. However, healthcare providers should also emphasize that there's lasting benefits that make the investment worthwhile. They need to describe what parents will experience when receiving training in behavior therapy. So the information that we just heard really, I think, feeling like as a primary care physician that you can explain what a parent is going to experience when they're working in one of these models is really important. And then also what to look for in a therapist to make sure that's the right the therapy being delivered is what is needed. If possible, primary care physicians should identify therapists who train parents in behavior therapy in their local area and share this list with parents. The CDC does have a resource document for healthcare providers or parents that they can use to help find a therapist. If you can move to the next slide. So finding a therapist, there are certain different kinds of licensed mental health providers who may provide this type of parent training and behavior therapy, and those include psychologists, social workers, counselors, and other licensed therapists. Next slide. And here you can see that there are some different online provider directories that are outlined. These different organizations, professional organizations, do provide online directories, and you can go to the website you see at the bottom at the CDC that is also a resource for finding a therapist. Next slide. So what should healthcare providers and parents look for when seeking a therapist? As we've heard, behavior therapy has been found to be most effective when delivered by parents. So healthcare providers and parents should be looking for certain things in those therapists and look for certain things that they're doing. They should ask questions of the therapist, such as, does the therapist work primarily with parents or work directly with the child? Do they explain to parents what parents can expect? Do they teach parents positive reinforcement, structure, and consistent discipline? Do they teach parents positive interaction and communication? Do they assign activities for parents to practice? And do they meet with the family to discuss progress? And then, finally, do they reevaluate, problem solve, and remain flexible so that they can adjust strategies? So these are some of the things that a primary care physician can use to help guide a parent through selecting a therapist who is going to be able to provide the right services for that child and that family. Next slide. These are some other questions that can potentially be asked of providers, including what's the therapy called? So as you notice, some of these therapies have a particular name assigned to them. What are the treatment goals of the therapy? What kind of evidence backs up the treatment that they are providing? How are they going to measure the progress and effectiveness of the treatment? How long should the treatment last? And what experience or training does a therapist have with this type of approach? Next slide. So the other thing, and I think Dr. Anderson also touched on this, is that the parents should feel comfortable with the therapist that they're working with. The therapist should check in with the family regularly to monitor progress and readjust strategies when needed. And the families really should be seeing some positive changes in their child's behavior within about 1 to 3 treatment sessions. If parents are not having a positive experience or not seeing improvement after several meetings with their therapist, and they're doing their homework and they're applying the strategies that they're learning, the healthcare provider really should check in with the parents to see what's happening and help discuss those concerns, help try to problem solve about why it may not be working. And then if the therapist seems to be unable to respond to the family's concern, the healthcare providers may need to work with families to find a different therapist. But I think before doing that, sort of asking some targeted questions of the family to make sure that they are getting what they need from the sessions, and they're also applying those in homework, I think is really important. Next slide. So there are instances, and certainly we are very supportive of the approach of behavior therapy first for these young children, so children under the age of 6. But behavior therapy may not be an option for all children, and there are certain instances where medicine may be appropriate for young children. It's important that healthcare providers help parents understand the risks and benefits of all available treatments so they're best prepared to make the appropriate choice for their child. The American Academy of Pediatrics guidance does describe appropriate use of medicine in young children with ADHD. If behavior therapy does not provide significant improvement and there's moderate to severe continuing disturbances in the child's function, then clinicians may prescribe methylphenidate to children under 6 who have ADHD. In addition, when an evidence-based behavior therapy is not available, the clinician does need to weigh the risks of starting medicine at a young age or early age against the harm of delaying treatment. So clearly there is some clinical judgment that needs to occur. We do know that for elementary school-age children, so 6 to 11 years of age, the clinician will often provide FDA-approved medicine for ADHD with or sometimes in addition or with behavior therapy, and preferably they have both. A recent study by Pelham and colleagues, and I know we heard mention of that earlier, suggests that school-age children also do better when they receive that behavior therapy first before adding a medication, even when it's clear that medicine is indicated to address some of the symptoms and behaviors. So, the bottom line is that we can't tell you what will work for each individual child, and we recognize that treatment decisions are best made when there's a discussion that happens between the parent and the child's doctor. And in some cases, medicine will be a part of this discussion, but we do know, and we've heard a lot of information today about behavior therapy and see it as a proven tool that really can make a difference in the life of a child with ADHD and their family. Next slide. So in summary, healthcare providers and families can work together to make sure that children with ADHD are receiving the most appropriate treatment. Healthcare providers should assess a young child with ADHD symptoms using the American Academy of Pediatrics clinical practice guidelines. They should discuss treatment with parents and explain the benefits of behavior therapy, including improved behavior, self-control and self-esteem, better relationships and reduced stress for families, and benefits that are lifelong for both children and families. They should refer parents to a therapist before prescribing medicine in these young children. And they need to be looking for or helping the families find a therapist who teaches parents skills to better manage a child's behavior and strengthen relationships, and that encourages parents to practice between sessions, that is regularly monitoring the progress and then adjusting strategies as needed. And finally, a primary care physician should follow up with the family during and after the treatment to confirm that there is progress and improvement in symptoms. If improvements are not occurring, they need to problem solve with the family. Sometimes that's, interpretation by the family of what's going on and figuring out a better strategy. Other times it's finding a different therapist, but clearly this ongoing discussion and relationship between the family, the child, and the child's doctor is really important in making sure that that they've got the right situation for all involved. Next slide, and you can see at the bottom of this that there are some resources. That you can learn more both on the CDC website as well as the National Resource Center on ADHD's website that can provide more information on what we've talked about today. Thank you.
Great. And thank you all so much, Dr. Anderson and Dr. Peacock, for your excellent presentations. Before we move into the question and answer portion of our webinar, I want to remind everyone that the recording from this webinar and the slides will be provided in a follow-up email. You can access the recording and slides within the next 2 weeks at the link provided on your screen. You may also still receive CMEs and CNEs by viewing the recording in its entirety and completing the evaluation form. So please, once those are posted, please share broadly with your colleagues. With that, we are now ready to take questions from the audience. So the first question, let me pull them up. So earlier, while Dr. Anderson was presenting, I have a question specific to questionnaires. So the question is, what are examples of other questionnaires to measure progress to be used with PMT, so Parent Management Training, or other BPT, other than the ECBI for children ages 7 to 12?
So do I get to go after that question?
Yes, go ahead. Yep.
Good times. So Matthew, great question. I think it's always good to think about what questionnaires actually have both, an established research literature behind them and also can be used to track symptoms. The thing for the ECBI, though, is if you Google it, it works up until age 16. Now, for most of us, when we say it works, the ECBI itself has a lot of symptoms that do sound like they're for younger children. So even though it's normed up to age 16, you're absolutely right that in clinical practice, a lot of clinicians may not use it. In terms of treatment measures measuring ADHD symptoms, I tend to favor either the Conners, which is a measure that's in widespread use around ADHD, or the SNAP. Which the SNAP is actually named for its creators, which I think are Swanson. I forget the 2 letters in the middle, but then also Pelham, who we've been talking about. But the SNAP has measures of both ADHD symptoms and behavioral symptoms, as well as can be used to measure or get baselines on side effects for if we're going to add medication interventions later on, where we might have that possibility. In terms of behavioral symptoms, I think the measure that's in most widespread use outside of the ECBI would be the Child Behavior Checklist, or the Achenbach Child Behavior Checklist, oftentimes abbreviated as CBCL, or the entire system itself is abbreviated as ASEBA, A-S-E-B-A. But the CBCL is often used to look at behavioral symptoms as well as to get kind of a sense of all kinds of other symptoms that could be present and also might be contributing to behavior or ADHD symptoms. With the CBCL, I think one caveat is that it can be somewhat so generalized that it's not as sensitive to within-treatment changes. So it's kind of a good idea for a pre- and post-treatment measure, but may not be as sensitive as something like the ECBI. Another measure I think is in widespread use is the BASC, B-A-S-C, and that includes measures of aggressive behavior, oppositional behavior, and it's normed for specific age ranges. But those are the ones that I mainly use in my practice.
Great. Thank you, Dr. Anderson. So I'll go to the next question, and I know you all covered this, and this is related to cost and insurance. So in your experience, have you had any success with insurance paying for this? And what is the average cost to the family to get behavior parent training?
So I can maybe start with that, and then Dr. Anderson may have some thoughts on this too. Clearly, varies throughout the country on availability and also cost. Typically, when a therapist is working and the child is involved in that, a lot of the codes and billing practices that are set up with that can be covered through insurance. It sometimes is more challenging when there's a parent involved. So it's a model that's set up where parents are doing parts of it separately than the child, but in other places that is covered. There are also some systems, sort of state systems, that are looking at how they can provide these services. We provided, and maybe this resource can be sent out later, we provided some examples when we released our vital signs on ADHD. We did what we called a town hall meeting, and that was recorded, and so maybe we can send it out to the participants. But it described some models in different states, in Pennsylvania and also in Maine, where they have been able, through a state systems perspective, have been able to provide services for families. So clearly, there's still work to do. Some of the work at CDC is looking at what policies we're looking across the country at what policies have been put into place through different state insurance plans and those kind of things that have set up systems to payment systems to sort of figure out how to pay for this. I don't know if, Dr. Anderson, you have anything to add, maybe since you are a provider of this, if you have some thoughts on that.
I can definitely add. I mean, the thing is, I've been in situations in which we've been billing insurance, situations we've billed state-run insurance like Medi-Cal when I was working in California, and situations where people are engaging in private pay and then getting reimbursement from their insurance later. And what I can say is that, in general, for a lot of these behavioral parent training models, particularly, say, helping non-compliant child and parent-child interaction therapy, these do end up getting, for the most part, covered by insurance, partly because the CPT code we're billing under, 90847, or family psychotherapy with the patient, is covered under insurance. And, families can usually get a large portion of the cost of treatment reimbursed because those coaching sessions are considered family psychotherapy. And under many insurance policies, or even state-run insurance, a certain number of parent sessions, parents alone, and that's the CPT code 90846, are allowed as long as we're still involving the child in sessions for the most part, or for a certain percentage of the sessions. So we actually have fairly good success at getting a large portion of the cost reimbursed by insurance. I think the major obstacles we run into are sometimes when folks are using a model that may involve a lot more time meeting with parents and didactics, we might have to get creative about how we use the session time in order to make sure that it's still falling perhaps under something that might be covered by a family's insurance. For a model like Incredible Years, it's often billed under 90853, which is group psychotherapy, and that also can vary in terms of insurance coverage. In terms of private pay or the cost, I know that someone asked about the average cost. What I'll normally tell families is if they're paying for any portion of the session, if insurance doesn't cover a portion, or if they're actually paying out of pocket, thinking what would 10 to 15 sessions cost might be a great estimate of the average cost to a family in terms of getting the information that they need, getting a certain level of guidance or coaching from a therapist on applying the strategies, and that can give a family a pretty good estimate of what the cost of treatment might be.
Awesome. Thank you all. So the next question, and you all covered this a little bit, maybe you can speak a little in more detail about this. Is there a master list or official roster for approved or licensed parent behavior therapists by state?
I can jump in, Dr. Peacock, if you've got answers.
Yeah, I can start, and then I think you may have some other resources as well. So I don't know if we can put back on the screen. It's the slide that's called "Finding a Therapist Who Trains Parents in Behavior Therapy," and you'll see. And maybe I can move to that. There. Okay. You can see that there are a number of organizations, professional organizations, that do provide provider directories, and then the other thing, though, that because of some of the work that we did and when we were providing or creating this ADHD vital signs report, is that it is important to have those other things available so that parents can do interviews with therapists, because sometimes you're not able to find someone that is sometimes it takes a conversation with the therapist to find out that they are indeed doing, for example, parent-child interaction training or something like that, because that may be not evidence. But now let me turn it over to Dr. Anderson, because I'm sure you're going to have a good answer as well.
I mean, look, that question I think is a really common one, is trying to find somebody who from the outset you know is qualified. And there are a lot of different efforts, I think, across the country to create these kind of databases. A number of those are listed on this slide that we now have up on screen, slide 27. The other thing is that in terms of behavioral parent training, ABCT, which is the organization that's the Association for Cognitive and Behavioral Therapies, ABCT, has a Find a Therapist feature on their website that is meant to help parents find therapists trained in evidence-based approaches in certain states. And in most cases, the therapists on that Find a Therapist listing will also list the kinds of treatments that they do, and parents might find behavioral training in among those listings. So I find that ABCT's Find a Therapist is the first thing that I go to when anyone asks me for a referral out of state. The second thing that I go to is many of the forms of therapy have their own lists of providers by state. Unfortunately, for things like parent-child interaction therapy, Incredible Years, and a couple of the other models, there may be listings, but they don't necessarily have dedicated staff on that website who are updating the list at all times. So sometimes, the list is either small for a certain state or may not be accurate because they may not be asking therapists when they've moved. But a lot of times that can be a really useful resource in finding people who might be doing these particular treatments. The other thing that we recommend to families is to go to university training centers in clinical psychology or in social work, because when you go to any university or college in a particular state, it's very likely they have some kind of clinical training program in which some of these models may be used, or they may have trainees that they're training in them. And that what we'll sometimes do is we'll email the directors of training at those programs and ask them if they have any former students or colleagues in the area who might practice these kinds of treatments. And that provides another avenue of finding the right kind of treatment.
Awesome, thank you. So the next question is a bit long, so I'm going to just bear with me. So given the potential for misdiagnosis of ADHD in young children and the recommendation to refer for behavioral therapy as first line of treatment, is it always also recommended that part of the referral question to a behavioral health professional be confirmation of diagnosis or possible referral for formal assessment?
I can start. I mean, so typically, if this is a primary care physician who's seeing a child and has done some screening and is doing referral, I think the likelihood that whoever they refer this child to, who's a licensed therapist, is going to do some evaluation themselves. So I think that there's often a differential diagnosis, especially in these young children that have sometimes the most severe symptoms. Sometimes it's a little difficult to understand what's going on, and so clearly that might be further evaluation by the therapist. There may be further evaluation by a subspecialist in pediatrics, such as a developmental pediatrician or a child psychiatrist or a neurologist. And so I would expect that would happen. What we do know that even if the child does not have ADHD, but they have another behavioral concern, we do know that this type of parent behavior therapy training is going to be helpful to different degrees based on regardless of that diagnosis. So I think that that's a really good point, is that sometimes it takes a little longer to figure out exactly what's going on, but certainly these approaches are going to be helpful for parents as they are trying to manage difficult behavior in their children.
I only have one point to add there, and that is that for most parents, if they're going from, say, their pediatrician's office to a therapist for an assessment, what we'll often tell them to do is just make sure that the therapist is asking a wide range of questions that both rule in ADHD and also go through the process of ruling out other possible causes. So we want a therapist to not only be trying to confirm the symptoms of ADHD might be there, but to also rule out depression or trauma or anxiety or learning-related issues or sleep problems or any number of things that might contribute to a child looking distractible, inattentive, getting less, kind of out of a certain environment than they might otherwise get. And what we expect, as Dr. Peacock was saying, is that most of these clinicians will be fairly complete in those intake appointments in trying to make sure that they're making the right diagnosis. In many cases as well, we already know that there may be some major behavioral challenges, and whether or not we're absolutely sure that ADHD is present, behavioral parent training can be useful no matter what. One thing just to add, because it just gets at two of the questions that are out there. Teresa and Lynn, the Vanderbilt is fantastic. I just hadn't been thinking of it, and you're absolutely right that it's publicly available. The ECBI is unfortunately something that you have to pay for to use. So it sounds like a great idea, and I'm glad you added that to the discussion.
Thanks, Dr. Anderson and Dr. Peacock. So the next question, how effective is BPT for foster parents who have custody of young children or juvenile youth who have ADHD?
Sorry, can you repeat the question? Sorry.
Sure, not a problem. This question is related to foster parents. So how effective is BPT for foster parents who have custody of young children or juvenile youth who have ADHD?
So I do know, and I am actually going to turn this back to Dr. Anderson, but I do know that there have been some approaches and some research looking into that, and there is effectiveness in a foster parent being trained in these same kinds of approaches and then working with the child. But I'm going to turn that back to Dr. Anderson to add some detail.
Sure. The main thing is that many of the approaches for behavioral parent training, although I would say particularly PCIT, parent-child interaction therapy, not only have been applied to populations like foster parents or youth in the juvenile justice system or people who may have engaged in child abuse before and were trying to prevent recidivism, but they've also been shown to have equivalent effectiveness with these populations. Anecdotally, I worked for 3 years exclusively with foster and adoptive parents, and can tell you that PCIT, as well as behavioral parent training, is highly effective in those populations. In terms of juvenile youth who have ADHD, Elaine, oftentimes people are talking about children older than the age group that we're talking about right now. So it may not be kids under age 6, but the approaches that have been used to or that are effective in those populations may involve similar principles, but are trying to apply it across a number of much more complex systems. So multidimensional kind of approaches, things that use the same kinds of behavioral principles can be effective, but of course there's a lot more complicated system there.
Great, thank you. So another question from the audience. So they said that this is great, but there are not many therapists trained in these practices. Is there any work that you all know of, Dr. Peacock or Dr. Anderson, being done to bring these evidence-based practices into graduate schools of social work, counseling, and or psychology?
I agree with Marcy's assessment. There are unfortunately not as many therapists as we would like trained in these practices. I don't exactly know how to answer the question more specifically than to say there are a lot of initiatives being done to bring this to every school of mental health and every level of training to ensure that folks move forward with evidence-based practices. The issue that we run into on a policy level is that as a country, we still have much more consistency in, say, medical training than we do in psychological or social work or counseling training, and that there are organizations that are working to change that, like the Association for Psychological Science or ABCT, as I've mentioned.
And in addition to that, we are working with some of the creators or the writers of the different therapy approaches that were discussed in Dr. Anderson's talk, and looking at, are there ways to adapt this? Are there ways to use an online approach? Are there ways to work with other professionals that maybe not a licensed psychologist, but a licensed clinical social worker, and those kind of things? So those are those approaches are in the works, because clearly we recognize that there is a need for more therapists out there that can provide this really good evidence-based approach.
Great, thank you. So the next question, one of the webinar attendees is looking at the possibility of implementing PPP via online delivery. This is largely due to availability of providers in rural areas and cost. Can you comment about the efficacy of online delivery versus in-person?
Jackie, it's a great question. The jury's still out. I think a lot of people are looking at innovative ways of delivering these services, especially in rural areas and where we need more low-cost access. The issue is that at the moment, while there's lots and lots of research on telehealth and online delivery and the factors that contribute to effectiveness there, we can't say that it's yet equivalent to in-person delivery methods, but there's at least a lot of research trying to make sure that it is as efficacious and showing that it's a promising approach. And with PPP, this is one of the more researched methods in terms of delivery. So if it's coming from the PPP knowledge base, it's likely to be useful. You just don't know if it's exactly equivalent.
And I will add to this, and this without the, I think it's important to understand that if there are, if the gold standard is not out there, there are certainly tenets of these practices that we outlined in this talk, and I think it's important that parents seek therapists who approach things with these basic tenets. So making sure that there's a focus on the relationship, making sure that there's a focus on positive behavior, and those other things that Dr. Anderson outlined.
Great. All right. So your next question, it seems like someone's kind of expressing frustration in terms of communication with therapists. So she was wondering, do others, or maybe you can provide some suggestions on problems that she is having as it relates to getting feedback from therapists, even when she has the appropriate releases in place on a patient that has been referred to a therapist for behavior parenting training, for example. She indicated that it makes it very difficult for the clinicians to know what she has already done and then what they are going to do if that communication is not in place. So any suggestions or feedback or comments on how to overcome challenges with communicating between therapists and providers, primary care providers?
So, I mean, I can say sort of from a global perspective, yeah, absolutely, having those releases in place so that there is communication between the therapist and the primary care physician is really important. What I've found sort of in practice is that it really depends on the different organizations or the different facilities where families are going, what form a particular facility uses, and so really it's, I think, on the onus of the providers, both the physician and the therapist, to ask families to fill out those releases. It's incredibly important that people take a team approach to this, because keeping the primary care physician in the loop, as well as the therapist and the family, really is going to provide the best care for that child. And really those, so that two-way communication is important. Sometimes I think people do that through written communication. I certainly have had that, where a family has brought me, something little, sort of saying, this is the basic tenets of what somebody has been working on in the sessions, or vice versa. Sometimes it's a quick conversation. The other ways that I've done this sort of in practice is that sometimes there has been the opportunity to actually have a phone call where we're all on a phone together for a brief time, just to make sure that we're all on the same page. But absolutely, that communication needs to happen, and is going to be a little different dependent on the arrangement.
I thought that answer was great. That was good.
Cool. So I'll give you the next one, Dave. Do you think food choices are an important part of the behavioral plan?
So I think it's a really thorny question. I think because a lot of people are very interested in how diet might affect behavior. The thing that I think is kind of the stock answer that we give around this question is that healthy diet is kind of a tide that lifts all boats, in the sense that whether you have behavioral issues, ADHD, depression, in general, if you're eating better, it should have some positive contribution to mental health. At the same time, there is no evidence that any dietary changes are an effective treatment for ADHD. So, I tell parents often that we will tell them if we have things that have been studied and shown to not be effective, and things that haven't been studied. And in this case, elimination of food dyes, gluten-free diets, elimination diets, taking certain things out, vegetarianism, none of these things have necessarily been shown to have an effect on ADHD symptoms. And that's why I would not say that food choices themselves are an important part of a behavior plan so much as they are an important part merely of a healthy lifestyle.
The only thing I would add to that is that sometimes there are clearly, things that a child eats, and they may not feel good after they eat that, and and so if there's something like that happening, then maybe a discussion with the pediatrician or with a gastroenterologist, if the pain associated with a food, or if a child has reflux or something like that, I think that's worth a discussion, because certainly when we see children that have pain related to food, for example, or pain related to anything for that matter, behavior can get worse. And so, like we were talking about before with a differential diagnosis, when you're seeing difficulties in behavior, it's important to think about the different maybe causes or contributors to that. And so,
that was a fantastic medical perspective there.
So that's why it's good that we've got different perspectives on, but certainly, underscoring what Dr. Anderson said, which is that food elimination diets to treat the ADHD symptoms is not where we should be going.
Great. And so do many pediatricians who have integrated medical behavioral practices have the ability to do these within their own practices? So do these, meaning implementing behavioral parenting training in their own practices?
Was the question was pediatricians doing this in their practices?
Correct.
So Correct. there are different practices throughout the country that do that. I know that if just picking sort of one of the therapies that we're talking about previously, the Incredible Years program, you can actually go to their website and they talk about some places where they've implemented that in primary care. I'm sure that there are other models where, say, PCIT is offered by a therapist, and they're co-located in a primary care pediatric practice. So there are different models that have been used to do that.
Great. Thanks, Dr. Peacock. And also, can one of you speak to whether there are any CE courses a pediatric nurse practitioner may be able to take to learn how to implement this in a primary care practice?
And I think many of these models of behavioral parent training offer trainings across the country if you Google them and then go to their kind of training websites. So PCIT International, which is kind of the dominant organization on the East Coast, has a website where they announce trainings all over the country. At the same time, PCIT for Traumatized Children, which is still very much effective for behavior but also is focused on populations of kids who've experienced trauma, is very dominant on the West Coast and does trainings all up and down the West Coast. Incredible Years does trainings all over the country, as are trainings for parent management training and other models. So I think it's something where a lot of times these do involve continuing education credits and can sometimes involve a fun trip to an exotic locale.
And then in addition to that, these different models that we've been discussing do have sort of different prerequisites for who can provide that care. So, for example, Triple P is a program that is not confined to just being provided by mental health providers. So, some of this is figuring out sort of who is qualified or who has the prerequisites to do a particular approach.
Great. So I have about 3 minutes, so I'm going to ask this last question. So I ask you to be brief because I think this is important. Can you address the specific therapies, behavioral parent treatment therapies that may be focused on Latino families? This attendee said that they've been researching similar programs to Triple P in the Latino community.
So I'm sorry, I don't have any particular information on therapies that have been focused on Latino families. They've all been adapted.
I can talk about that for a second. I think there are 3 approaches to this within the behavioral parent training world. Many of the therapies have been translated into Spanish. The second approach is within the PCIT world, there's actually a particular adaptation of PCIT, and I'm forgetting the acronym right now, but it was specifically created for Latino families. Obviously, it comes a little bit fraught with both sensitivities and some issues in the sense that it's adapted in kind of a very general way to aspects of culture in, I believe it was done in Southern California and in Puerto Rico. But there are, of course, I think efforts underway to try to make sure that these treatments are reaching all populations and are also relevant when they get there. And I think that PCIT and Triple P in particular have been able to think a little bit about that question.
Great. Thank you all so much. That's all the time we have today for questions. Let me again thank our webinar faculty, Dr. Peacock and Dr. Anderson, for their excellent job that they did today. We're so grateful for their willingness to share their expertise with us today. And again, our gratitude to the CDC for their sponsorship of this webinar series. Before signing off, we'd like to remind you that this webinar is a part of a 3-part series on evidence-based and evidence-informed parent training and behavior therapy for young children with ADHD, which is brought to you by the National Council for Behavioral Health. We'd like you to please join us for our final webinar for licensed clinicians and other therapists on Wednesday, June 9th. You can register at the link that's located on your screen, or you can go to our website. You can copy and paste that to your browser. And thanks to all of you for joining us today. As you exit the webinar, a survey will pop up on your screen. Please take a few moments to fill out the survey, as this will give us an opportunity to learn what your needs are and to identify how we can further improve our webinar. To obtain CMEs and CNEs, please note that you must complete an additional evaluation form located at the link shown on your screen. It's a SurveyMonkey form. So this link to this form will also be sent to you in an email following this webinar. Please copy and paste this link into your browser and follow the instructions indicated. If you have any questions, please contact my colleague, Crystal Canare, at the email address on the screen. Again, on behalf of the National Council for Behavioral Health, we truly hope that you found this information provided during today's webinar helpful, and we remain committed to promoting full health and wellness for children and families with ADHD and behavioral challenges. Thank you again, and have a wonderful rest of your day.